So we spoke about obesity, and Dr. Martin spoke about diabetes. You have seen that the gut may play a role in diabetes, and diabetes, even more than obesity, is really a worldwide challenge with almost 400 million people affected worldwide. So this is clear that if we have new solutions, they could be extremely useful. As you learn also, we learn from our friends surgeons that when we divert the proximal jejunum, we can improve the diabetes, and this comes from the pioneering work of Rubinho, especially after Roux-en-Y gastric bypass, which has shown that, for example, in this patient who was diabetic, the requirement in insulin therapy were decreasing very shortly after the surgery without any relationship with the weight loss itself, proving that there is probably another mechanism of insulin sensitization. And the first study which have been done included the placement of a sleeve in rats, of either a complete sleeve or a fenestrated sleeve, and they have shown in these comparative studies that those rats which had been treated with a complete sleeve, bypassing the contact of food with the proximal duodenum and jejunum, had a tolerance to glucose which was dramatically improved when compared to controls or those having a fenestrated sleeve. So as you heard from Guido, the first attempt to mimic the surgery by endoscopy was the use of EndoBarriere, or duodenal sleeve, which was a good idea because bypassing the proximal duodenum is a good idea, and I would say a bad technique because this was a stent implanted in the duodenum, and the duodenum is the most fragile part of the GI tract, so it induced some complication, mainly minor but severe in some cases. And as you heard before, the FDA multicentric trial was stopped in 2015 for major complication, and there is obviously a need, if we think about an implant, to look for other device. But nevertheless, if you look at the results which were published, especially by the group of São Paulo, using this technique, of course it was a bad technique because 13 patients only out of 28 were able to complete the 1-year implantation without complication. But for those who completed this 1-year implantation, you see that there was a dramatic decrease in fasting blood glucose, in fasting insulin, and in glycosylated hemoglobin. And this benefit was even maintained 6 months after retrieval of the sleeve. So there are other groups which are working on implant, especially a group from Hyderabad, which name is Metamodics, which are looking for a sleeve which would be implanted through the pylorus in order to decrease the aggressivity to the wall of the duodenum, but the results are not yet available. So the next way to mimic surgery in order to bypass the proximal duodenum is to do anastomosis, and there have been some magnetic anastomose device which have been developed. This is probably the one which has been up to now the most studied. It's a magnet which can be inserted into a catheter, and this is an octagonal magnet, and you see how it goes out of an endoscope and how it makes a jejuno-ileal anastomosis, which is a surgery which was done several years ago with significant complication, but in this case the blind loop remains open, so we don't have long-term follow-up. This was an animal study, and you see that this was acting mainly to a weight loss, not a direct effect on diabetes, but of course you see the pigs which were treated were significantly smaller than the other one, and this is the first human study which was done in Ostrava in Czech Republic, where you see that there is of course a significant weight loss, but also a dramatic decrease of glycosylated hemoglobin, especially in a diabetic patient, and you see the way it's down, and this ends up with a jejuno-ileal anastomosis with a native path which remain open, which might suggest that it will decrease the risk of bacterial pullulation, which was associated with surgical technique. So this was the first pilot study with this technique. We can also think about stents for creating anastomose, gastrojejunal anastomose, or even using a nodes technique to have a gastro ileal or gastrojejunal anastomose through a nodes technique. This is going into the peritoneal cavity, making an anastomose with the hot axios, and I think that our friend Marc Bartet is investigating that in an animal study by now. So the next question is it really necessary to bypass the duodenum? As you heard from Dr. Martins, it's quite clear that there are some diabetes-associated change to duodenal mucosa which are linked to high-calorie diet, and it has been shown in rats and in humans that over the time, the mucosa of the proximal duodenum is changing, and then you have seen that it may be involved in the insulin resistance. So the first study which was done and still not published was looking whether in rats, by instead of placing a sleeve, doing a scratching, an erosion of the mucosa, an ablation of the mucosa could increase the insulin sensitivity, and in fact, apparently, it was increasing the insulin sensitivity in rats, and it came to the idea of developing duodenal mucosal resurfacing, which was based on the observation that surgery improves metabolic disease, that bypassing the duodenum alone improves insulin resistance, and you have seen that even in endocrinology world, there is more and more evidence for that, and that there is also a compelling evidence that duodenal mucosa is altered in patients who have diabetes. It's altered in patients who may have metabolic syndrome by diets and high fat and sugar diet. So this duodenal mucosa induces some hormonal signals, and which is probably, most probably, involved in insulin resistance. So this means that maybe, and most probably now, with the research which is evolving, a physiological abnormality of the duodenum, which may be induced by high fat and sugar diet, might be at the root of the metabolic syndrome, which involves obesity, of course, but also type 2 diabetes. And the next major cause of liver cirrhosis in the next century, which is the non-alcoholic fatty liver and non-alcoholic steatohepatitis. So this is the example of the technique which has been developed by an American company. This is a duodenal mucosal resurfacing, which encompasses the use of a balloon in which you can insufflate hot water, and you have side ports which are used in order to create a submucosal injection in this patient. So if we go to look at the aspect of the technique, you can see that I will just try to show you the technique consists in going over a guide wire into the duodenum from below the papilla, then doing a successive submucosal injection, followed by ablation with hot fluid up to 94 degrees over the whole length of the third part of the duodenum up to the angle of Thwaites. So ablating all the mucosa, which is located between the papilla and the Thwaites angle. And this ablation is followed by a rapid restoration of the mucosa. And when you look at the result, after ablation, you see that you have a complete ablation of the duodenal mucosa on all the ablated area, which is quite impressive and quite homogeneous. And within less than 1 month, you have a kind of reset of the duodenal mucosa, which is replaced by a new and probably more healthy one. So there have been some studies which have been done looking at this technique. The first one was a pilot study done in South America, where they had compared the treatment of a short segment with the treatment of a long segment. A short segment was 3 centimeters, a long segment was 10 centimeters or more. And you see that when treating a long segment, they were able to observe a significant change in fasting plasma glucose as well and in glycosylated hemoglobin. So then there have been a multicentric, not a randomized, but a multicentric trial in Europe, which was conducted, which confirmed this result, showing a decrease persisting at 1 year of fasting plasma glucose and glycosylated hemoglobin. And interestingly, this decrease was even more prominent in those patients who had greater residual beta cell function, so an higher insulinemia at baseline, suggesting that, in fact, it increased insulin sensitivity. There were also some additional factors which were improved, like urinary microalbumin, which was dramatically decreased up to 6 months after treatment without significant change in the weight of the patient. So we come to the feature of insulin resistance, which is one of the major pathophysiological events of the metabolic syndrome, which is involved in a series of the associated disease, but mainly in type 2 diabetes, but also, as I told you, in what will be, for hepatologists, the next major cause of liver cirrhosis and hepatocarcinoma, which is the non-alcoholic steatohepatitis. So it might be, Paul, that at the next meeting, we will have not only an endocrinologist, but also maybe an hepatologist on our table to moderate. And when we look at the results of both the pilot study and the multicentric European study, looking at of course, this protocol were not designed to look for non-alcoholic steatohepatitis, but we observed that all those patients who had an elevated ALT or AST at baseline had a dramatic decrease in their ALT level over time up to 6 months after this treatment, while their tolerance to glucose was also improving. So suggesting that by modulating insulin resistance by this intervention on the proximal jejunum, we could also affect the development of non-alcoholic steatohepatitis, or at least its effect on the liver and its progression. So there are studies which are focusing on that, which are ongoing, but it might be also a major topic, which is mainly even more interesting than diabetes, because for diabetes, the endocrinologists already have very good treatment for managing diabetes, but as you know, for NASH, we don't have any pharmacological treatment available by now. So will metabolic endoscopy be the next paradigm shift? There are some novelties which suggest that it might be. The endomiluminal approach to the duodenum may decrease insulin resistance. It comes with some new question. Type 2 diabetes would be a reversible disease. It would be a digestive disease. Endoscopic modulation of anatomy or endoscopic intervention on the duodenum mucosa might reset this affected duodenal mucosa and may improve the treatment of type 2 diabetes. It might even have an effect of NAFLD and NASH, which would be even more interesting in terms of offering to patients a treatment when no treatment is available. So there are all question marks. But it's evident that diabetes is a pandemic and the treatment is not satisfactory by now. NAFLD and NASH are the next leading cause of cirrhosis and hepatocarcinoma, because hepatitis C will disappear within 10 years. And if surgery for type 2 diabetes, which is already performed in several centers, and for NASH, becomes an accepted option, then transoral endotherapy will naturally be the next option because it will be less invasive. And I think that if duodenal resurfacing works and works on midterm or on long term, it could be the least invasive non-pharmacological option in the future. Thank you very much for your attention.